Welcome to this educational activity focused on stroke risk in patients with type 2 diabetes. I'm Silvio Inzucchi. I'm a professor of medicine in endocrinology at Yale School of Medicine and medical director of the Yale Diabetes Center. And today I'll be talking about what healthcare professionals can do to reduce stroke risk in their patients with diabetes, specifically type 2 diabetes. So there has been a flurry of activity in the pharmaceutical industry over the past couple of decades, bringing new therapeutic agents to market focused on reducing blood glucose in patients with type 2 diabetes. When I started my training, we had essentially sulfonylureas and insulin, and I think I'm showing my age here, but certainly over the past 5 to 10 years, there have been some new formulations of older drugs and some new drugs themselves that improve hemoglobin A1C, and specifically, as we'll talk about, the GLP-1 agonists and the SGLT2 inhibitors, drugs that actually reduce the risk of cardiovascular events. So we now have 7 major drug categories to treat hyperglycemia in patients with type 2 diabetes. Insulin and sulfonylureas are the older agents. Metformin, a biguanide, also quite old, been available in the United States since 1995. The thiazolidinedione is not as popular as they used to be, specifically pioglitazone. And then the DPP-4 inhibitors, sometimes nicknamed the gliptins, the GLP-1 agonists, which are mainly injectables, although one version of semaglutide is now available in an oral formulation, and the SGLT2 inhibitors are sometimes nicknamed the flozins. On this chart, we've shown the average reduction in hemoglobin A1C, but for today's talk, importantly, we'll be focusing on the cardiovascular impact of these medications. Insulin and the sulfonylureas are neutral, as are the DPP-4 inhibitors. The TZDs are interesting. It's a bit of a double-edged sword. Pioglitazone has been demonstrated to reduce cardiovascular complications in patients with diabetes as well as prediabetes. But because of their tendency to increase sodium retention, they can predispose patients to heart failure. So both a positive and a negative in terms of the cardiovascular system. Metformin may reduce MACE, or major adverse cardiovascular events, although the quality of that data is not good. The data is not quite robust. And as mentioned previously, 2 newer drug classes, GLP-1s and the SGLT2s, clearly reduce major adverse cardiovascular events. And as we'll see, the GLP-1 agonists and the TZD pioglitazone appear to have a specific benefit in stroke risk reduction. Now, the PROACTIVE trial was published a number of years ago, and actually one of the first large cardiovascular studies in patients with type 2 diabetes. These are individuals at high CV risk that were randomized to the TZD pioglitazone or placebo. And over time, there was a significant reduction in their cardiovascular event rates. The secondary outcome of MACE was reduced by 16%. And you can see that the stroke risk itself was reduced by 19%, although with small numbers, this was not statistically significant. However, if you focused on those patients that were randomized in PROACTIVE with a baseline history of stroke, the effect was quite striking, with a 47% risk reduction in recurrent stroke outcomes. That's the first time any diabetes therapeutic has been associated with a specific reduction in stroke risk. We conducted the IRIS trial also a number of years ago. Here we used the TZD pioglitazone, but we're interested not in patients with diabetes, but in those with insulin resistance. Remember, the TZDs are insulin sensitizing drugs, and many of these patients with insulin resistance ended up having pre-diabetes. At the end of the day, the risk reduction in these individuals that had either baseline stroke or TIA was 25% reduced if randomized to pioglitazone. So this was mainly focused on reduction in ischemic stroke with a neutral effect on hemorrhagic stroke. So between PROACTIVE in patients with type 2 diabetes and the IRIS trial in patients mainly with prediabetes and insulin resistance, along with a smaller Japanese trial, there was a meta-analysis recently published that concluded a 32% overall risk reduction in stroke in patients who were taking this thiazolidinedione. As mentioned before, the GLP-1 agonists, these are incretin-based therapies, mainly injectables. And here, a number of them, including liraglutide, dulaglutide, and semaglutide, have each been associated with reductions in MACE. In the LEADER trial, this was mainly driven by a strong effect on reducing cardiovascular mortality. And in the REWIND trial, as well as the SUSTAIN 6 trial with dula and semaglutide, respectively, these appear to be at least strongly driven by very powerful effects on stroke risk reduction. Here's a meta-analysis that pools data from 8 GLP-1 randomized trials. These are cardiovascular outcome trials in patients with type 2 diabetes, and the conclusion was an overall 16% relative risk reduction for stroke. And here's a larger meta-analysis, this focusing on 28 randomized clinical trials, including a number of phase 3 and phase 4 trials. And we can see that the overall effect on any adverse cerebrovascular outcome, and in some of these studies, they pooled patients with new TIAs and patients with stroke. Suffice to say that the risk reduction was in the same order as the previous meta-analysis, about a 17% reduction. And here you can see individual GLP-1s. And in green, we've shown you those studies that have been significant for stroke risk reduction with dulaglutide and 2 versions of semaglutide, injectable and oral. Do these data translate well to the real world? The answer is yes. This is from Taiwan, over 6,000 patients with diabetes treated with GLP-1 agonists. Overall, there's about a third reduction in stroke, but not statistically significant. But if you now look at patients who are taking the drug for a longer period of time or at a higher dose or a higher cumulative dose, there appears to be the emergence of statistical significance. So this is now buttressing the effects of the GLP-1s that we see from the RCTs. A second meta-analysis is pulling data from Denmark, as well as from the large international mega stroke study. We can see that the 2 drug categories that are clearly reducing stroke risk include the GLP-1 agonists and the thiazolidinediones. The mechanisms of the effect of the GLP-1s is still not clearly understood. There appears to be some data suggesting both extracerebral, meaning effects on atherosclerosis, as well as intracerebral effects to decrease the injury from stroke, although there are no data that I know of that suggests that stroke, when it occurs in a patient managed with the GLP-1, is necessarily smaller than in individuals treated with other anti-diabetic agents. But I think most of the experts in this field, atherosclerosis types of investigators, feel that by reducing body weight, obesity, reductions in blood pressure, dyslipidemia, and glucose itself, this can add up to have an overall beneficial effect on reducing the progression of atherosclerosis. Well, now these exciting data have really begun to inform treatment guidelines for patients with type 2 diabetes. On the left, we see the ADA standards of care from 2023, clearly recommending a focus on cardiovascular risk reduction. So individuals who have ASCVD, including stroke, or indicators of high risk should be treated either with a GLP-1 agonist or an SGLT2 inhibitor with proven cardiovascular benefits. Now, it's interesting to note that the ADA does not specifically emphasize the important distinction between GLP-1s and SGLT2s, in that the GLP-1s have clearly strong benefit in stroke risk reduction, whereas that's not been demonstrated for the SGLT2s. But to be fair, both SGLT2s and GLP-1s reduce MACE, major adverse cardiovascular events. There just appears to be a differential effect in stroke risk. And also the mention, at least, of the thiazolidinedione, specifically pioglitazone, in patients to reduce further cardiovascular events. On the right side of the slide, we see the ACE guidelines. This is the American Association of Clinical Endocrinologists. very similar to ADA. If a patient has type 2 diabetes and has ASCVD or at risk for ASCVD, then either or a GLP-1 or an SGLT2. But here the ACE group specifically identified that the GLP-1s appear to have a proven benefit for stroke risk reduction, not seen with the SGLT2s. And also mention, and this is hearkening to PROACTIVE and IRIS, as we mentioned previously, in those patients with insulin resistance, prediabetes, or type 2 diabetes that have had stroke or TIA, the consideration at least for pioglitazone as an add-on to the overall antihyperglycemic regimen in those individual patients. And finally, from the DCRM group, this is a multi-specialty group that put out some practice recommendations for type 2 diabetes patients, here now specifically delineating long-acting GLP-1s and pioglitazone as drugs that can not only lower hemoglobin A1C, but reduce the risk of stroke. So to summarize, 3 classes of glucose-lowering agents have been demonstrated to reduce cardiovascular events in high-risk individuals with type 2 diabetes, including those that had stroke. These include the SGLT2 inhibitors, the GLP-1 agonists, and the thiazolidinedione pioglitazone. But only the GLP-1 agonists and pioglitazone have been shown to reduce stroke risk as a MACE specifically, with the GLP-1 agonists showing in CV outcome trials and meta-analyses a significant reduction in stroke risk, particularly with dulaglutide and semaglutide. And now guideline recommendations highlight the importance of incident and recurrent stroke prevention. We talked about the ADA guidelines. Dr. Cheng, in just a few minutes, will talk about the American Heart Association, American Stroke Association guidelines, both recommending GLP-1 agonists and the SGLT2 inhibitors to reduce the risk of cardiovascular events, and also the consideration of pioglitazone in certain individuals. And finally, the ACE group recommends GLP-1 agonists with proven benefit to reduce stroke risk specifically, and also the consideration of pioglitazone to reduce this risk as well. Thanks so much for your attention.